lunch is over. We'll start this session this afternoon with Paolo Zerbinati. Sorry for my Italian. I don't have any any skills. Zerbinati, sorry. So thanks, Paolo, for being here. You will talk about minimally invasive skeletal surgery for the treatment of neurological cavus foot.
The cause and deforming mechanism underlying pes cavus is complex and not well understood. Factors considered influencing development of the pes cavus include muscle weakness and imbalance in neuromuscular disease, residual effect of congenital club foot, post-traumatic bone imbalance, bone malformation, contracture of the plantar fascia, and shortening of Achilles tendons. Among the cases of neuromuscular pes cavus, 50% of the cases is due to the Charcot-Marie-Tooth. And we will talk about the cavus foot in Charcot-Marie-Tooth. The most common deformity in cavus foot is a plantar flexion of the first ray that gives a forefoot pronation and secondary in-foot varus. The pathomechanic of the deformity is due to the imbalance to the muscle. The muscle primarily affected are the intrinsic muscle of the foot, the tibial anterior and peroneus brevis that doesn't work, and the strong antagonist, such as the long extensor, peroneus longus, and tibial posterior, that overpower the weakness muscle, resulting in a cavus foot deformity. So the plantar flex result from a weak tibial anterior and a strong peroneus longus. As we know, the peroneus longus is evertor, but the plantar flexor, the fourth ray. The supinative forefoot will compensate over time with the in-foot varus that in the first time is reducible and it became irreducible. The weakness peroneus brevis will also allow the tibial posterior to gain mechanical advantage and add to the varus position of the in-foot. In adduction, we have the power of the tibial posterior that bring the foot in varus. The problem of cavus foot in patient are the difficulty in fitting the shoe wear. The patient use plantar and special shoes, pain beneath the metatarsal heels and along the fifth metatarsal base, claw toes, difficult walking or running, and an unstable gait. The compensation mechanism for the patient with Charcot-Marie-Tooth is very common. As we can see here, a patient with a double cable foot. We can see here the position of the trunk and the position of the double limb support during the gait. If we see what happened during the normal physiologic monopodiatric support, we know that in frontal plane we can see the center of gravity that is exactly in the middle of the trunk, and the cup, the center of pressure, fall into the support base of the foot. This is permitted by adduction of the lower limb and calcaneus valgus. This is the normal position of the foot during the monopodiatric support. As we can see here, the center of gravity. What happens if we have the deformity of the foot? The foot is no more in valgus, but it becomes in varus. The central portion is outside the foot. So we move toward extension, toward the external position of the foot to permit the good position of the central pressure. So the first compensation is just to enlarge the base of during the walking. Increase the distance between the feet on the front, which allows the patient to increase the surface of plantigrade correction of the foot. This is a first try to combine a new walk, a new position. But the center of gravity move toward the opposite side, and so the trunk must be moved toward the limb instead to permit the correction of the center pressure. So the lateral inclination of the trunk toward the support side permits the center of gravity to be lateralized and to be exactly in the center of the foot. So two types of combination, as we can see here in this patient. If the enlargement of the foot is sufficient, the patient walk without moving the trunk and the cup remain central. The only way to maintain a good position is to accelerate the swing speed. If necessary, if we have the deformity of the foot, in which the position of the foot might be more abduction to permit the correct plantigrade position, as we can see here, we have the completely movement of the trunk during the gait. We can see here the patient before surgery, and we can see the patient after the surgical procedure. On the left side, you see still rotation of the trunk on the right side, and after the bilateral correction, as we can see here, the correction of the trunk during the gait and the normal adduction position of the foot. These are a normal combination of posterior alignment for the cavus foot during the gait. So what are our aims in surgical goals? First of all, to realign the foot to achieve a plantigrade foot, correct all the deformity while preserving joint motion. We don't like the surgery that co-involve that reduce and block the joint. Balance the difference between agonist and antagonist, and not to fix the foot, to leave treatment option available for the future. We must remember that the CMT, sarcomatous, is a progressive problem. So we must do everything that is soft tissue balance and osseous corrective procedure. As we talked you before, there are procedures in which the joint is preserved in a joint in which the joint is sacrificed. Looking at the pathomechanism of the cavus foot deformity, we must remember the role of the peroneus longus to give the forefoot protection, the role of the modification of the cavus in varus and in-foot varus, and the retraction of the flexible structure, the decantering structure. So, goal of surgery is to correct both the problems, which means that usually, always I do the tenodesis of peroneal longus to peroneus brevi, just to leave the extrotation, the movement of the plantar longus as extensor of the foot, as the versor of the foot, but to avoid the position of the false metatarsus. We have to correct the forefoot pronation. That means we have to make the osteotomy of the false metatarsus. And if we need, if it's not flexible, we have to treat the valgus calcaneus osteotomy with the galtus calcaneus varus. And we have to make all the percutaneous release of the structure that has become contracted. I use a very soft tissue percutaneous procedure, both on the soft tissues, both on the bone. In the soft tissue, I use a lot the gastrocnemius percutaneous lengthening with the needle. We can see here the position of the foot before and after surgery. In a very thin lower limb, it is possible to make the just a gastrocnemius release with a needle. In some other patient, it is difficult to make the percutaneous release, so I use the gastrocnemius endoscopic lengthening. I use the same tool that I use for the carpal tunnel release. As we can see here in the video, we can see the probe inside the muscle, and you can see on the right, on the top, we have the gastrocnemius aponeurosis, and we make the cut of gastrocnemius, and you see when we go back to the muscle, you see just the muscle without the gastrocnemius, and you see on the left the correction of the foot after the endoscopic lengthening. Another procedure that we must do is the correction of the false metatarsal. I use the mini-invasive surgery, the same that I use for the correction hallux valgus. I use a particular drill with some particular type of motor drill. Use with a fluoroscope. We see exactly the point of osteotomy. You see here the base of the metatarsals, and we can see here the video. You can see here, while I'm cutting just the dorsal part of the bone, as we can see here. And now after the cut, I leave intact the plantar surface of the bone, and after the dorsal extension osteotomy, we can correct the metatarsals plantiflexion. You see, with just a gentle pressure, we can correct the position of the foot. With this procedure, the patient can walk the day after surgery with the cast, the plaster, and we leave the cast just for 2 weeks, and we take off the cast. The same procedure can be done for the release of the fascia and hallux, abductor hallux. As we can see here for the needle, very small incision, both abductor and percutaneous fascia. So the same can be done for the flexor to release. If we have the invarus, calcaneus invarus, that is no more flexible, that is deformity, we have to correct the calcaneus. We have to see what happened during the Coleman-Andreasi test. If we have a positive Andreasi test with no correction of the hindfoot with the forefoot position just on posterior, we have to correct the calcaneus. There are different types of osteotomy of the calcaneus. I use a percutaneous osteotomy in the case in which you had not to correct a bad position of the calcaneus. There are different types, like a Dwyer is a oblique incision of the calcaneus, posterior part of the calcaneus, in which you correct both the varus and you correct the lateralization and you correct the rotation of the calcaneus. This is very simple, very easy, and it permits to not to be so big a surgery like the calcaneus Dwyer opening surgery procedure. You can see here just I put the needle, key wire, just to see the exactly position of the section of the bone with the scalpel. Here you can see on the fluoroscope, we identify the position of entry of the drill. This is the drill. This is the drill. We see with the fluoroscope, we identify exactly the position of the drill, both the dorsal and the plantar aspect of the calcaneus, and we can correct and make a completely cut of the bone. And we can see here on the right, after the osteotomy, we can move the calcaneus. We can move toward external, so correct the varus, and we put the key wire to make the correction. If we need, if you don't have to make the gastrocnemius lengthening, if you want to leave the gastrocnemius muscle intact, you can make the double incision of the bone, and you can put the foot in the right position. You see what happened. The posterior part of the calcaneus is upright because you have both correct the calcaneus and both correct the retraction of the Achilles tendon. Associated procedure, as I told you before, most of the time I do the peroneus longus to peroneus brevis tendesis. We can open the medial capsule. If you have very bad retraction, I make the whole arthrotomy of the talus. We can make the transfer if we need to correct the balance between inversor and eversor. Usually we make the transfer of the tibial posterior tendon, or the splat if you see that if you on gait analysis have a big activity on the tibial anterior. Not so common in the patient with Charcot-Marie-Tooth, but you can use. More common is one of the most used tendon transfer is the splat. in which we're going to transfer just half of the tendon, of the tibial posterior tendon, and we move to the peroneus laterale tendon. We see some cases. We see the patient before and after surgery. This is a very small child with a bad deformity, and we can see before and after surgery. We can see the correction on the trunk. You see the trunk toward the right side, and the correction of the trunk, the position of the foot after the surgery. Another case in which we have made the correction of the left hip, left foot, we can see the position of the foot before and after surgery, and you can see the good correction and the good dorsiflexion of the foot. As I told you before, if I do just the gastrocnemial lengthening and the percutaneous osteotomy of the false metatarsals and the percutaneous release of fascia plantar, I leave the patient in a hospital. The day after surgery with the cast, the patient start to walk, and I take off, I remove the plaster, I put the cast, and they stay with the cast for 3 weeks, and after 3 weeks I remove the cast and I put a normal shoes, or if you need just a correction with a plantar sole. Another case, again with a deformity of the foot. As we can see here, all the patients are in gait analysis. We use a lot of gait analysis just to see the patient before and after surgery, to measure activity of the muscle, and to have an objective and to have evaluation for identify the good resolution of surgery. You see here, you see the good position of the foot in frontal pain on the sagittal and the trunk. And another patient, again, in the children patient, I used to make the surgery on both sides in the same operating session. In the adult, I prefer to do first one side and other 6 months the other sides. Here the patient 3 months after the surgery on the left side, and we can see here on the kinematic of the foot, we have the correction of the left foot, but still a drop foot on the right side. Here, the video after 3 months. We can combine the kinematic, the graphic of before and after surgery, so we can see the difference of the patient. The red one is before surgery, and the blue one the after surgery. And again, the patient after 3 months after left side and 3 months after right side, so 6 months after the fourth surgery. A good position of the foot, good walking, good balance of the trunk, and you see the kinematic, you see the good position of the foot, and no drop foot in walking. And you can see here the difference between pre-op and post-operative. So it's very important to know what happened. Thank you.
Thank you very much, Paolo. It was very interesting. Does someone have any question?
I have a question. Thank you for that. That was a lovely presentation. Paolo, could you comment on 2 things, potentially? First thing to ask is, I saw some of your patients end up still with weakness of the tibialis anterior. So do you brace them? That's one. The second has to do with, how do you decide how much to do when you do your transfer, when you do your tenotomies? How much do you do? What is it based just on your clinical judgment when you have the patient in the bed, or do you use some other methodology?
The decision of surgery is due to the clinical observation and the gait analysis. With the dynamic MG, we can know exactly the power of the muscle of a tibial posterior and tibial anterior before surgery, and we can predict the result of the tendon transfer. So if I have to do a tendon transfer, I decide prior surgery with gait analysis. And the different type of surgical option can be decided in the operating theater. So I start with examination after anesthesia. If I need, I do the gastrocnemius lengthening. If I need, I do the percutaneous fascia plantar release. If I need, I do the flexor to release. It depends. It depends for the correction, for the type of correction I do to the sides. But most of the time, I must know exactly what I will be done, so I can say to the patient exactly what they expect of the surgery. So for me, the decision must be done before surgery. For the weak tibial anterior, I use a lot the tendon, the TP transfer, TP, the tibial posterior. Sometimes you don't reach a good dorsiflexion of the foot, but you use the tibial posterior, the tenon suspensor. So our aims is to avoid the use of the brace as a cast for the patient, if we can.
Merci beaucoup pour cette très belle présentation. Deux remarques et puis une question. La remarque, on opère beaucoup de CMT à Garches. La remarque, c'est que je trouve, je ne sais pas ce que tu en penses, qu'il y a une énorme variabilité des tableaux cliniques. Et que par exemple, on a des patients qui ont un tibial postérieur qui est certes fort, mais pas de triceps. Et donc, est-ce qu'il ne faut pas plutôt mettre le tibial postérieur sur le triceps et renforcer derrière plutôt que renforcer devant? Donc, je trouve qu'il y a une variabilité. Première remarque. Et qui pose une question, je ne sais pas comment tu fais, c'est, puisqu'on est dans de l'évolutif, je trouve que le plus dur pour nous, c'est comment ça va se passer dans 5 ans. Et donc, le transfert d'aujourd'hui, ce n'est pas forcément le bon transfert pour dans 5 ans au regard de l'évolutivité du déficit. Donc on travaille avec Antoine Perrier pour essayer de faire des modélisations. Voilà, mais comment on arrive dans nos décisions à avoir une vision, je ne sais pas comment vous faites, voilà, de se dire comment on préserve les 5 ans. Voilà. Et puis le constat que je peux faire, c'est que finalement je suis frappé du nombre de patients quand on fait que des gestes, entre guillemets, partie molle ou ostéotomie, qui se retrouvent avec des instabilités parce que l'évolution continue à se faire, à qui on est obligé d'aller stabiliser les coupes de torsion, à tel point que maintenant, nous, on est plutôt plus agressif dans la stabilisation des coupes de torsion, parce que les patients, en fait, ils n'aiment pas y retourner 2 fois. Donc, tu n'as pas du tout parlé des arthrodèses de coupe de torsion. Je reconnais qu'on en fait beaucoup plus qu'on en faisait à une époque au regard de cet caractère d'évolutivité et donc d'essayer d'anticiper au mieux pour éviter que le patient retourne souvent au bloc. Donc j'aimerais bien avoir la façon avec laquelle, comment vous voyez le côté prospective et la place des arthrodèses.
Paolo, don't be afraid. Even French-speaking people did not fully understand the question, so don't be afraid if you are not able.
C'est vrai, j'étais pas clair. C'est très clair pour moi.
There was one more piece, and that is the progression. What happens since we know this CMT is a progressive disease? How do you plan for that?
When we treat a patient with Charcot-Marie tooth, we must be aware of our progression, and the patient too must be aware about the possibility of a re-surgery. So it's common for the pathology. So when I treat a patient with Charcot-Marie tooth, I just talk to the patient and say, no, okay, now the problem is you have pain on the first metatarsals, you cannot wear normal shoes, you have to walk just with shoes, you cannot walk without shoes. So we define the problem, and I give to the patient the different type of solution that we have. Usually I start with very soft tissue percutaneous surgery or minimal invasive surgery, just to permit the patient to walk the day after surgery, because I don't like to do very big surgery. But you must bear what happened. Sometimes the patient must be has to be followed the years after surgery. Maybe 1 year after, he still the problem of the cloud 2, so we bring the patient in the operating theater where we make the correction of the cloud 2. Maybe after different year, he has a progression of the hind-foot varus, so we have to open the calcaneus and correct. I don't like to do arthrodesis because I have not big experience in arthrodesis. I have done several times, we have a lot of problem with arthrodesis. I think that if you correct, if with your surgical tool, you correct the position of the foot, you avoid the patient the arthrodesis. I have done different type with intramedullary nail, the arthrodesis. It really works well, the arthrodesis. You really correct the foot, but the patient must remain without walking for 3 months. It's a very long time for the patient without muscle. That's why making the decision in the Charcot-Marie tools, we must be aware about the weakness of the muscle and the problem of the long-standing immobilization. As I told you before, in Italy we have a big experience with the gait analysis. To make the study of the tibial posterior is not so easy because you must use the fine key wire MG study. It's not so easy to study the tibial posterior, but we decide before surgery if to make the tendon transfer of the tibial posterior. Sometimes, even if the tibial anterior is not so have not so big activity in a gait analysis, we make this splat procedure. I sometimes use both splat and both splot procedure. I always do the tenodesis of peroneus longus to peroneus brevis. The aim of the surgery is that correct the difference between inversor and eversor. So that's why we use a lot the tendon transfer.
Yeah, another part of Philippe's question, Paolo, was why are you doing splot instead of transferring the tibial posterior directly on the Achillean tendon? Why are you not transferring the posterior tendon directly on the Achillean tendon? And why splot?
There are different type of splot procedure. In 25 years I have done everything. I have tried to transfer all the tibial posterior, half of the tibial posterior, just to leave half from the medial and to transport half on the lateral side of the peroneus. I try to make the division of the tibial posterior and move one to the peroneus longus and the other one to the extensor of the peroneus tertius or the extensor digitorum longus. You can do whatever you want. It depends on. It's a good muscle. Sometimes there's a good activity, and so it's a good power. The problem in the tendon transfer that is one-shot surgery. So you must decide exactly what to do, and you have to do exactly what you want. Not so easy, but yes. I think we can do many times. He was talking about the transfer to the TP2. I have maybe done once. I don't like the transfer that needs a long time of immobilization. That's why I prefer not to do that.
Professor Perrineau, Grenoble, thanks for your talk. I understood you like using movement analysis, gait analysis, before surgery, maybe also for teaching and for research. But I was wondering how much is this gait analysis useful to guide the final decision for surgery or not for a given patient? Is it really an additional value or not?
I use a lot the gait analysis with cerebral palsy and hemiplegic patient. That is a wonderful tool because it really gives you the chance to know exactly what you have to done with the tendon transfer. In the Charcot-Marie tools, it's much more difficult. I use a lot the tendon transfer through research for myself because I must know exactly what happened before and after surgery. For the patient itself, because the patient sees a video before and after surgery. And sometimes I think that the gait analysis is useful, as I told you before, for the splat procedure because we know that the tibial anterior tendon doesn't work in the Charcot-Marie tools. It's not so true because sometimes I have seen some tibial anteriors that work with the gait analysis. I make the splat procedure and it works. So I think that is a solution.
No, after, because yes. So thank you. Thank you very much for the discussion. We will try to discuss after, but you have another plan.